Tim, it was almost like we got together then to talk about translating what we know from clinical trials into clinical practice, because I'd say we did actually get together and we've sorted all this out and our talks were running smoothly. We actually didn't, but it does follow the same theme. I've been pretty passionate, obsessed around non-invasive ventilation for many years, especially with the patients that are chronic respiratory disease, which is a real focus. And interestingly enough, the ideas and the thoughts I've had about weaning from mechanical ventilation have been driven by, many years ago, an article written by Dr. Goldstone over there in the corner. And it was lovely when I walked into that and saw him first, because part of John and I, well, you worked a little bit for me, but we worked in John Moxham's physiology group. So this whole idea of seeing all the physiology here and then relating it back into clinical practice is really important. I know that was part of the session this morning. What I'm going to do is concentrate on clinical trials. You will know about the clinical trials that are in non-invasive ventilation, but I will go over these again to drive home the key messages in the particular patient groups. What I'm actually going to show you is what's happening out there based on the audit data that we have from the British Thoracic Society, joined with the ICS as well. So it's really important we understand what we think we should be doing and what we actually are doing. So just as an outline, we're going to look at acute exacerbations of COPD. Obviously, this is the area where most work has been done. And then we're going to look at the acute hypoxic respiratory failure patients in terms of non-invasive ventilation. A group we're seeing more and more and more of is the obesity-related respiratory failure patients. These are the guys coming through the front door of hospital. And what I'm really terming acute core pulmonale. They're really walking in 15 litres overloaded with a CO2 which is probably slightly higher than their oxygen. But they've developed sleep disorder breathing, part of their obesity, and they've got obesity-related respiratory failure. A group that we manage, and we've got about 120 Duchenne's that we look after, which is neuromuscular patients. And then the idea of using non-invasive ventilation in weaning and the kind of pros and cons for using non-invasive ventilation there. So the acute exacerbations of COPD. This is the stuff that's easy, really, when you think about the literature, because these patients are bloody sick. The acute exacerbation patient who comes in, whose CO2 is elevated, whose bicarbonate or whose pH is low, is very highly likely to die in the next year if they survive that episode. Most of the patients will survive that acute exacerbation episode that they receive non-invasive ventilation when they come through the emergency room. But if you look at those patients, if you have two of those patients next door to each other, one of them will be dead at a year. However, I don't know which patient will be dead at a year. And that's the work we're trying to do at the moment, to understand the patients at the highest risk. Because an exacerbation of COPD with hypercapnic respiratory failure really indicates you're moving towards the end of life. And 80% of these patients keep coming in, and we've got a program of research looking at trying to prevent COPD readmissions and these severe readmissions. So what about the randomised control trials? Well, these are very, very well described control trials. There's meta-analysis around these trials, and we know it reduces intubation rate. We know it reduces ICU length of stay, mortality, hospital length of stay. Most importantly for the healthcare organisation, it reduces cost. So all of these factors look for this to be a good way to treat patients who are hypercapnic, acidotic with COPD, to be given non-invasive ventilation. But that was all in the ICU. It took actually moving to the UK studies, because we had limitations to access to the ICU for these patients at that stage. And so using NIV on the wards was driven by a study which came out of King's College Hospital from Julia Bott and John Moxham, the senior author on that, which showed a reduction in mortality using as non-invasive ventilation against standard therapy. And then this more recent, which was the YONIV study, the Yorkshire Non-Invasive Ventilation Study, intubation rate and increased mortality, or reduced intubation rate. And then you see here, I've just written here, increased mortality. And just to highlight what that means, these patients, when they stratified them out, the ones with a pH less than 7.3 had a higher mortality. So although patients with acute exacerbations of COPD coming through our front door, we're going to give them non-invasive ventilation as standard therapy, we have to be mindful of the fact of those who are significantly acidotic, and the average pH of the patients coming in St Thomas's is 7.21, so all of ours hit this. They need to be managed in the appropriate environment for them to receive appropriate care. So we've got the demonstration of NIV on the general ward setting, and the reason this study by Wood et al. Showed that there was an increased mortality is it really delayed intubation. And that's what this study did. They used conventional against non-invasive ventilation, but it delayed intubation, and these patients got delayed intubation and ended up dying. So it's really trial design that failed. So these are questions we ask ourselves the whole time. What we're going to do when it goes wrong, it doesn't work, are we going to intubate the patient, and are we going to resuscitate the patient? And that's for me thinking about predictors of failure and predictors of success or survival. And around failure, you can have a pretty good idea by looking at a patient, the patients who might or might not fail. Now, where I see it's quite obvious to see a patient might fail, the edentulous patient who's got a very, very probably malnourished, because I think body mass index is a big predictor of outcome. But those who end up, because of the mask fit, having a lot of mask leak, well, those guys are going to be the ones that you need to focus on, because they're going to fail. As always, the magic hour of things not getting better. Excess secretions. Putting non-invasive ventilation on and then kind of going, right, well, let's see what happens over the first 24 hours. If you're not clearing secretions, and this is very apparent in patients who have pneumonia, who have excess secretion load, and you can't actually get bronchial toileting, physiotherapy to clear the secretions, they're going to fail. So that's the time where, if you feel escalation to invasive ventilation may be not appropriate, what we've tended to use, or what we can use, is to use a mini tracheostomy. So you put a 4 mil tracheostomy, a cricothyroid stab. That's very helpful, and it's very useful. In fact, where we've used it quite successfully is with our neuromuscular patients. Neurologically impaired patients, and what you heard a lot about, and what our main interest at the moment as regarding non-invasive ventilation, is patient ventilatory synchrony. So how can we predict survival of these guys requiring invasive ventilation? So the guys who go on to receive invasive ventilation, and this was a great study by Martin Wildman from Sheffield, and what they did, they took all the COPD patients who were coming through the ICU, and they spoke to clinicians, and they said, do you think they're going to live, or do you think they're going to die? And I think that's a great, somebody coming through the front door, are they going to live or die? And this is the important outcome that you get from this. So just to orientate you, you've got actual percent survival, and then you've got predicted survival. So this is what we thought was going to happen, and this is what really did happen. And what you see is, if you really think someone's going to survive, 80% survival, yeah, 80% are actually going to survive. Where the disparity comes, and that's where you want this blue line, which is the line of unity, but we're a bit off that, you get the dotted line, you're saying 10% survival, and in fact 40% are surviving. So that really means we are extremely pessimistic about this patient group. And it's interesting, when you look at the health-related quality of life of the patients on a follow-up study they did, the patients said after going through the ICU they felt better than they did prior to admission. And when they were asked if they would do it again, the overall feedback from the patients was yes, they would. So we just need to take this into account when we're looking at patients with COPD. Now, when we're thinking of the patient who may or may not survive an acute exacerbation of COPD, I think it's really important to go on the idea that a patient who's got COPD and multi-organ failure is very unlikely to survive. And that is probably more important than what their FEV1 is. Being on LTOT and housebound, from the literature, and I'm sure from people's experience on occasions, doesn't really seem to predict the outcome that we would expect. It makes us make decisions early on, but of those patients that get into your ICU or out on housebound, and we obviously receive a lot of COPD patients who are on the weaning service, they do actually get weaned from mechanical ventilation and discharged. I appreciate they're in the last year of their life, but at least they're in the last year of their life outside, and we can make escalation plans thereafter. And I think that's really important for making sure we engage with the patients as they come through. I think nutritional status is a major predictor. We know from the long-term studies of COPD, and those of you may have heard about the BODE score, BMI, obstruction, dyspnea and exercise capacity, but I think nutrition is wholly important. But lucky enough, McDonald's has fixed all that, so now we're moving to the guys that are overweight, and there's now a really interesting discussion going on about obesity being good for COPD, not for the fact it may be good for you, but in terms of pulmonary mechanics, because these are hyperinflated conditions, and then you're adding a restrictive defect, so you may actually be reducing the hyperinflation. So we've got some interesting data, physiological data coming out, which we'll be telling everyone to get fat with COPD. So short term is the acute illness, which all sounds very sensible. Long term, when I'm seeing someone in clinic, it's all going to be related to their severity of their COPD and their comorbidities. So I think COPD is something we should be less nihilistic about and more positive about, because the outcomes we have are very favourable and the patients manage to get home. Now this is where the link to Tim's talk comes in translating clinical trials and clinical practice. So we know all this data about COPD, and we all knew that. And then what happened was guidelines, BTS, ICS, Royal College of Physicians, and then again, this is just the abbreviated version. So it was then an audit to see how we were doing against these standards. And what you see is this was the report, but I've just picked out 3 standards here because it was easy just to pick, to make the point. So the first standard was start NIV if the CO2 is greater than 6 and the pH is less than 7.35, despite optimal therapy. Pretty straightforward. I think we'd all agree with that one. And what was found for that was that happened in 51% of the cases. So this whole idea that we know what we're doing, when it comes to process and implementation to clinical practice, it becomes very much more difficult. So the next one, repeat arterial blood gas after an hour, or do it after every change in settings. You see, it's not great, is it? 79% of the patients had a gas repeated in the first 24 hours. We didn't even get close to the hour. And then escalation decisions, which I think are really important. We all, I don't think anybody in this room would say, with acute exacerbation of COPD, I want to make a decision about what we're going to do when it goes wrong, and everyone would agree with that. Unfortunately, we just don't see it happening. With 59% of the patients getting that kind of decision. And then when you go into the detail of this, the people making the decision were actually quite junior. And then down to the SHO level. And I think these decisions should be made by much senior medical personnel than down to the SHO. So how do we improve translation? Education, well, nobody's going to say, wow, that's a brilliant idea. So we did a survey around education, and we divided it up into the respiratory, R and C is respiratory and critical care, nurses, therapists, junior therapists, the junior docs through to the middle grades, through to consultants. And it was divided up into indications, technical, practical, and published evidence. And so this was a survey of 30 questions, and we sent out. But the great thing was we compared it to 118 people who should know nothing about non-invasive ventilation. Oncologists, renal physicians, nurses. We went out to the care of the early wards, so we were really comparing it. Everybody's seeing what the answers are already. But what you find is the bits highlighted in yellow, there was no difference from the group that supposedly knew very little, which really does pick up the point of education along here. Now, in our institution, the physiotherapists tend to be the patients setting up the non-invasive ventilation in the emergency room. And the nurses are obviously making the change in settings during non-invasive ventilation. But what we've done is we've targeted these groups. It doesn't so worry me so much because these guys go home at 5 now, and so they don't stay at night, so it's not a problem. But we've got to make sure the people that are there 24 hours a day actually understand the way we're trying to deliver the service and the way we're trying to improve patient outcome. That's COPD. That's the data that's been produced on COPD since 1998 and really informs us of how we should be managing them. When you come to the acute hypoxic respiratory failure patients, what happened was non-invasive ventilation, brilliant, and it was going to be used for everything. We didn't need to intubate another patient ever again. But obviously it wasn't quite as simple as that. And this is the non-acute cardiac pulmonary edema data, and this is pneumonia data. And there was this study, obviously a historical study now from Massimo Antonelli, looking at mortality, and it really was showing that NIV was not very successful compared to invasive ventilation, which was what this study was. So it's a negative outcome for non-invasive ventilation. However, when they did non-invasive ventilation about standard therapy for community-acquired pneumonia, although in those guys who had no chronic respiratory disease, there was a signal coming through that pneumonia and COPD had a better outcome than standard therapy for non-invasive ventilation, which I think is really interesting, because the group, I think, at the higher risk of failure for non-invasive ventilation who've got COPD are the guys who've got pneumonia. So that, for me, is slightly counterintuitive to the data that was previously shown. And then when you look at the univariate and multivariate analysis to find the risk factors for failure in the hypoxic group, you can see if you're older, if you're sicker, if you've got primary lung issues or ARDS and community-acquired pneumonia, and you've got poor gas exchange. So no surprises there. So patients that are sick, who are requiring inotrope vasopressors, then using non-invasive ventilation is probably not going to be so helpful, and to gain control and using intubate and ventilate. So what do they do for clinical practice? Well, you can use it in early acute hypoxic respiratory failure, but it's got to be done in the right place. This is not the general ward setting, which is what the Yoniv study in COPD was, which was in fact what was happening. For some reason there was some removal of patients into the wrong environment, and then maximising the changes that you're going to do, clinical changes you're going to do early. And multi-organ failure, well, there's no point moving for non-invasive ventilation. So what about heart failure? And I was really interested to see Tim's meta-analyses, because it really reminds me that how rubbish meta-analysis is. So this is a meta-analysis of CPAP, non-invasive ventilation, or kind of standard therapy for acute cardiac pulmonary edema. It's a Lancet paper, loads and loads and loads, hundreds of thousands of patients. And what it really showed from this, you thought your practice, how's it going to change it? Well, it will. So CPAP versus standard, so it's intubation rate here, mortality here. So intubation rate, reduces intubation, CPAP, reduces intubation, bi-level, and there was no difference between the two. So I said to myself, well, you can use either, and probably CPAP's a bit easier, so you're going to be using CPAP. However, when you looked at mortality, you thought, for some reason, bi-level doesn't seem to do anything for mortality, but CPAP does. So, and there was no difference between these two, but overall, you turn around and say, perhaps we're going to use CPAP therapy. So that was very clear until this had more patients than the meta-analysis. This is a randomised controlled trial that was done in the UK. So these were the similar patients that they'd used in the meta-analyses, and what they found was, if I just highlight it and cut to the chase, there was no difference in any of the outcomes, with the exception of gas exchange getting better. So interestingly, if you give someone a ventilator, they ventilate, and their CO2 comes down. So, but the overall outcome from using CPAP or non-invasive ventilation, CPAP or non-invasive ventilation against standard oxygen treatment, and there was no difference. So that's really important, because we've got a meta-analysis guiding us into CPAP, and then we've got a randomised controlled trial which tells us that, in fact, using a ventilatory technology, CPAP or NIV, it doesn't seem to do much for the oxygen. It's no different from standard therapy. Now, interestingly enough, the machine they used was a low-flow CPAP machine. It was a low-flow generator. Well, I don't think we use that in clinical practice. They were using a low-flow generator. So I think it was a different study they did. And when you use a low-flow generator, and if you entrain oxygen, you can get to an FiO2 of about 0.4. Well, we put them on high flow and 100%. So it doesn't quite answer the question that it was set out to answer. So again, translating to clinical practice, yeah, I mean, we use CPAP quite readily in patients with hypocapnic, with hypoxic respiratory failure. Those patients with hypocapnic respiratory failure, we may consider using non-invasive ventilation. There's no doubt patients with acute heart failure get fluid accumulation in their airways, and that fluid accumulation in their airways causes airways resistance, like asthma, and so there's no doubt airways resistance in there, so to use a ventilator seems quite reasonable. So what about special circumstances, the guys that we're seeing more of? And I've been obvious, this is cardiorespiratory failure. Obviously it's not left heart failure, but they come in with primary right heart failure and acute and chronic respiratory failure. And this is the patients we're seeing, their aspiration rates, their difficult airways. They've got right heart failure, secondary polycythemia, and it's all to do with the fact that they've got sleep disordered breathing of one kind or another. Now this sleep disordered breathing, it's easy to find out, because they all get diagnosed with COPD. You've got somebody who's got a BMI of 50, and they've got COPD, and they've never smoked. And all you have to do is ask them whether they snore, and you're home and hosed because you've got the diagnosis. Do you snore, and are you sleepy during the day? Yeah, I have been for a while, okay. And your bicarb's 40. Okay, I think I've worked this one out. But it's really important that we do that really early, because they do get diagnosed, and the amount of patients we stop inhaled therapies for beta agonists and alike is huge. These dear patients are bloody difficult. You know, we all know this. These are the issues we're dealing with. And I see some of my nursing colleagues in the audience, and God, when we have our super obese patients on our unit, it really is a struggle. We have a gantry hoist now, which is a supersized me gantry hoist, which can take up to 300 kilos. So you know, we're moving into the super obese, and I'd like to hear our North American colleagues' views on this as well. So when you're talking about the complexities, you know, that always gets shown to me, and they always get reported as acute cardiac pulmonary edema, and God knows how you make that diagnosis when all you've got is a chap who's surrounded by a significant amount of adipose. So pretty easy though. Oxygenate, ventilate diureses, and Venusect if they've got a very high PCV. That is really, and the amount of patients we manage to just treat with non-invasive ventilation is substantial. And we use not quite the same as the ARDS, but you use a peak titration ladder and a pressure support ladder. And all you want to do is stop the obstructive events, stop the snoring. Don't over-egg your saturations. 86, 88, absolutely fine. You'll make progress as long as you don't go too ambitious. And then just stopping the central events and seeing the chest wall movement. If it fails, so this is interesting. Obviously, we're concerned about obese patients and their outcome on the ICU. Now, this data is French data, and it's not a randomised control trial. It's just an observational cohort data set. But it's got the patients who are invasively ventilated against non-invasive ventilation, and they divide them into success and failure. And here you see their blood gases. Now, when you look through, about 2/3 got non-invasive ventilation, 1/3 got invasively ventilated. And when you see the guys that were non-invasively ventilated who had success, the mortality was 0. So you're happy about those, but I want to find these guys. I want to make sure that these guys are receiving it. If it was a failure, it was higher than if they got intubated. Now, 24% as a mortality. The mortality for the unit of St Thomas's is 19.8%. So it's not far off the overall unit mortality on the mortality we're seeing here. But the interesting thing is, you perhaps can identify these guys as they come through the front door. And I'm talking about the NIV failure guys. Because, as you see, not surprisingly, 60% have got OSA diagnosed already. So you know they've got sleep disordered breathing, you know they've got respiratory issues. Now, the guys that fail weren't using their machine. So at home, when it's nice and quiet, and it's at night time, and they go to put on a mask, which is not blowing very hard, they can't wear it. Coming through the front door of A&E, when it's all catastrophe, and they're breathless, and they're struggling, and they're around there like this, and you go up to them and put a mask on, it's not going to work. So this, for me, is really important data to find out whether these guys are using. Because you may get these guys early and then just transfer them over to invasive ventilation. So what about mortality for obesity? Well, in fact, it's not as bad as you may think. The forest plot here, as you see, 30 is a fairly low amount of obesity now. So we'll be changing the figures soon. 30, 35 will be all right. But you see here, there's no difference in the forest plot. But when you're looking at hospital, when you're looking at duration of mechanical ventilation and length of stay, you do see some changes here. And then, interestingly enough, there seems to be some favouring for obesity for mortality. So they're in hospital longer, that's for sure, but their mortality outcome is not as bad as you may imagine. And then when you go to more data that's coming out in this area, and we go to look at the guys at 42 against 24, so a significant difference between these guys. You see there's no difference in length of stay or mortality and hospital mortality. So being obese doesn't necessarily say you're going to have a worse outcome through the ICU. Neuromuscular disease, obsessed with neuromuscular disease. We've got a lot of neuromuscular patients. And if we can get in early with non-invasive ventilation and get their secretions out, say using mini tracheostomy, then we can and avoid intubation and ventilation, then we've had a pretty good outcome and successful outcome with these guys. What I will say, if you have a Duchenne that comes through your unit, as well as obviously caring for the respiratory side, you've always got to keep in the back of your mind the cardiomyopathy. All Duchenne patients, inferior and posterior part of the heart will not work. It will be fibrosed. I don't mind if they have an ejection fraction necessarily around 30%, 35%, because in fact they don't do a great deal. But what we really need to know is when we've got somebody with very, very impaired cardiac function. But what you'll actually find is the majority of patients that come through they will have reduced cardiac function, but it won't be catastrophic like some of the ischemic cardiopaths you see. So for us, NIV, failure, intubate, extubate when the secretions have fallen, NIV, failure, intubate, tracheostomy or mini tracheostomy. Our decannulation rate for neuromuscular patients who have had a tracheostomy is virtually at 100% for the Duchenne muscular dystrophy patients. So they're very, they're very, very, very weanable as a group of patients. Now, non-invasive ventilation, we've gone through the acute, through COPD, through pneumonia. The obese patients, I think it's going to be more and more used with, and I think we should be using NIV with the obese patients, not going to intubation. And then the neuromuscular group, and now these patients that we see a lot of the difficult to wean. And can we stop them becoming difficult to wean patients? That's the question. And can we use non-invasive ventilation? This is really just my schematic for the whole idea of the difficult to wean patient. And you see here we go from full ventilatory support to liberation from mechanical ventilation, and then you get all these different groups along the way. Using non-invasive ventilation is not a new idea as it comes for extubation patients with chronic respiratory disease, and in this Stefano Nava paper, it was with COPD. So they took the patients that failed a 2-hour weaning trial and then randomised them to standard continuation of therapy or non-invasive ventilation. So these were COPD patients, came in after 48 hours, weaning trial, failed, here you go, these are the guys that are going to run. So, yeah, there was a significant difference in total days of mechanical ventilation, ICU length of stay, and mortality. This was a single centre study done by passionate experts who were good at this. And so that's where you have to take that into account. That's why you can imagine they did this well. A bit like Tim's saying, and the question came, do you pray? I've been praying for 18 years. Centres that are good at things will get better outcomes than centres that are just starting. However, this is the randomised control trial that was done thereafter, so multi-centre, and this was in Spain. So similar way forward, apart from they used the patient with persistent weaning failure. They didn't say COPD. They thought that would be too restrictive. Let's go for persistent weaning failure. So they did. 2-hour weaning trial, fail, randomised conventional treatment or non-invasive ventilation. And brilliantly, they showed that the total days of mechanical ventilation was less in the non-invasive ventilation group, length of stay, tracheostomy, ICU mortality, and hospital length of stay. So this was a positive outcome. using patients that have persistent weaning failure and then extubating onto NIV rather than leaving them intubated on conventional ventilation. This, just to say that is interesting as a study, because when you go into it, and it came with an editorial from Paolo Nevolesi, but the data's interesting because the groups who failed were mainly COPD and thoracic wall. So these are chronic respiratory failure patients, in effect, or chronic respiratory disease patients. So the signals coming through, non-invasive ventilation for chronic respiratory disease is potentially very useful. And this was a meta-analysis of that. And the ones I've highlighted in red, just to make it obvious, are COPD. So the majority of the work has been done in COPD. So this is non-invasive ventilation for weaning that was published in the BMJ, but it's all this data is mainly around COPD, and this is the forest plot showing improved outcome. So with that in mind, this is just to highlight a trial that Tim's involved in, we're involved as the Thomases in the pilot study, where we're not taking patients who have got chronic respiratory disease necessarily. What we're trying to do is do a trial where we're extubating patients earlier than necessarily we would have, but using non-invasive ventilation to do that. We've recruited so far about 10, Tim?
15.
Is it 15? 15 of only 800, so we're nearly there. This is for the pilot, because the way the health technology assessment runs now is that we need to prove that we can recruit and we've got everything sorted out before we jump forward and they give us hundreds of billions of pounds to do the trial, which they're not. But anyway, just keep your eye out for this, because this was a trial that went through the HTA call for this, and so it went through a number of iterations. And I think, Tim, when we first sat around in Warwick, it seemed like that was 1,000 years ago, probably, when we first started designing the trial. But it will be coming once the pilot's undertaken and this pilot's successful, then there will be a rollout. And this is a UK senior portfolio study, so obviously that comes with very attractive for everybody. Everyone's got great money. Yeah, so there'll be the money associated with the study. So which patients use NIV on? What do I do? Acute exacerbation COPD, tick. Slowly progressive neuromuscular patients with respiratory deterioration, tick. Guillain-Barré, intubate them. There's some great data actually for identifying Guillain-Barré patients who are more likely to require intubation. Those guys with a short presentation, those guys that when you go to examine them, they can't lift their head off their bed or shrug their shoulders. No surprise there. It's a neurological problem that's got an ascending, and once it's hit here and here, it's taking your phrenic nerves out, your diaphragm has actually been affected. So those patients, we would not say use non-IV on, unless you want to intubate them at 4 in the morning. And interestingly enough, there's data showing that these guys end up in quite severe difficulties because of the delayed intubation. Obesity patients, I think so. What about hypoxic patients? Yeah, I think so. Group I haven't discussed, the immunosuppressed. I think we need to consider non-invasive ventilation in immunosuppressed with pulmonary infiltrates. And to facilitate weaning, what do I never do? Proper severe asthma. I think that's destined for disaster. Hypoxic respiratory failure requiring other organ support. And as I said, the Guillain-Barré patients or the uncontrolled myasthenics who've got rapidly progressive neuromuscular disease. Thank you for listening, and I'll take any questions if there's time. I appreciate it.